We are live. We are live.
Yeah, Samir, you can start. Hello, Samir.
Ma'am, we are live.
Yeah.
Uh, Hello.
Yes, you can start.
Good evening, everyone. Good evening to all the respected members, executive members, the speakers, expert panelists, and thanks again to Ajit Babu sir, who has taken so much interest, and we are on to the second session. And I'd like to request our president sir to start the meeting. Thank you.
Welcome everybody. This is the third webinar of our OSOS society. This is well organized by the scientific committee, and I am very much interested on this webinar. We are having members from the AIS also. I welcome Dr. Sablin, Dr. Saitya, Dr. Shreya to take part in the discussion. Last but not the least, we are having Dr. Ajit Babu Madhi, our past president of AOS and a member of OS also. He is contributing his valuable time to taking part in the webinar. Thank you. Over to Parmita Madam, please.
Thank you, sir. Good evening, everybody. Vidya Vandate Amritam is wisdom that heals. This webinar series by OSOS is a torchbearer of knowledge, guiding baseline learning in ocular trauma across various subspecialties. It bridges the gap between theory and practice, promoting clinically relevant discussions that improve patient care. It acts as a melting pot of minds and brings together residents, fellows, consultants, and experts of national and international fame. And let us start. Over to moderator of today's session, Dr. Shweta Dhiman. Over to you, Dr. Shweta.
Thank you so much, ma'am. So, a very good evening, all. I would like to personally extend a warm welcome to all the esteemed experts in the field of pediatric ophthalmology and strabismus who have joined us from across various states. And thank you for taking out the time with us today. So, your valuable knowledge and insights and perspective will undoubtedly enrich our audience. So, with that, I would like to welcome our expert panelist, Dr. Sablin Kaur. She is Associate Professor at Advanced Eye Care Center, PGI Chandigarh. Welcome, ma'am. Dr. Sahitya Bhaskaran. She is Associate Professor, Pediatric Ophthalmology and Strabismus and Vision Rehabilitation at Arvind Eye Hospital, Madurai. Welcome, ma'am. Dr. Shreya Shah. She is the Pediatric Ophthalmologist and Oculoplastic Surgeon and Director of Dashti Netralaya, Dahod. A very warm welcome, ma'am. With that, I would also like to welcome our OSOS panelist, Dr. Vivek Wakad. He is the head pediatric ophthalmology and strabismus and neuro-ophthalmology at LVPI Bhubaneswar. Dr. Sucheta Parija, she is the head of the ophthalmology department and pediatric ophthalmologist at AIMS Bhubaneswar. Dr. Anurag Mishra, he is the pediatric ophthalmologist, strabismologist, and cataract surgeon heading Radharaman Eye Hospital at Cuttack. Dr. Ruby Maharana, she is the pediatric ophthalmologist and strabismologist at Apex Eye Care, Cuttack. So basically, pediatric ocular trauma is very important because we see a lot of injuries in our OPDs in which the children are getting the corneal tears, the injury of the natural lens and extraocular muscles. So today's webinar, we are going to learn about how to manage these cases and how to do the visual rehabilitation. So with this background, I would like to call upon our first presenter, Dr. Shraddha. She is a second year DNB resident at JPM Rotary Hospital. Over to you, Shraddha.
Good evening to the August audience. Ma'am, shall I share my screen now?
Yeah.
Is my screen visible to all?
Yes.
A very good evening to the August audience. I am Dr. Shraddha, a second year DNB from JPM Rotary Cuttack. And on the occasion of third webinar series of the OSOS, I shall be presenting from trauma to clarity, managing a corneal tear with traumatic cataract. So ours was a 8-year-old male child from Jajpur, Odisha. The informant being father, he presented with complaint of trauma to right eye with tip of a pen while playing with younger sibling one day ago. So child was of average build, vitals were stable, conscious and oriented to time place. On right eye, the vision was PR positive, accurate, PR was accurate, left eye was 6/6, face and ocular adnexa was bilaterally within normal limits. The right eye upper lid was swollen. There was intense conjunctival congestion. Sclera appeared to be normal. On examining the cornea, there was a linear corneal tear located inferiorly, extending from 6 to 8 o'clock, which was paracentral in location, and probably there was vitreous and iris tissue incarcerated in the wound. There was no cells and flare in the AC, but there was lens matter. There was a traumatic mydriasis and sphincter tear at 7 o'clock. But the consensual light reflex of the other eye was normal. Upon lens, there was a total traumatic cataract with a ruptured anterior capsule. There was no subluxation of the lens or phacodonosis. We could not see the posterior fundus of the patient. But upon dilated fundoscopy, the left eye fundus was completely within normal limits. So we went for all routine examinations and then counseled the parents and planned for a right eye corneal tear repair with lens aspiration along with anterior vitrectomy under GA under GVP. The OTS was 70 and the bed scoring was right eye open globe penetrating injury. So this was our case. There was iris tissue incarcerated, which we cut along with the vitreous. Then the AC was formed with visco. Then with a 10O nylon suture, 6 sutures were placed in the corneal tear, equidistant from the wound in a 3-to-1 fashion, not very tight, not very loose. Then along with the vanas, the anterior capsule was cut and opened from the site of the rupture. Then we performed a dry aspiration including in a Simcoes because there was already vitreous in the AC. Regarding the residual cortex, the vitrectomy cutter was used to remove it. And there we found a big posterior capsule dehiscence. Hence we left the patient aphakic. Then we can see with a dialer, we are checking if there is any residual vitreous in the AC, and then the wound was closed. On the post of day 1, the visual acuity of the right eye was CF1 meter. IOP was completely normal. AC was formed with intact sutures. Red glow was present and PI was patent. As the child was very much photophobic and irritable, we could not take a photo, unfortunately. Then all treatment was given as follows. Upon post of 1 week, we again called for a dilated fundoscopy where the posterior pole of the right eye was completely fine. And upon X-ray orbit, it was normal with no evidence of any foreign bodies. After 6 weeks, the visual acuity was 3/60 with the aphakic correction of +10 diopter, coming to the visual acuity of 6/24. The retina was on and posterior pole was fine. Upon keratometry, we found the SFI power was +20 diopter, and we planned for a right eye corneal suture removal in the second sitting along with SFI and anterior vitrectomy under GA under GVP. So this was our case. With a Rexus marker, we are marking 2 points 180° apart. And then a 360° peritomy was done with cautery. Then infusion port was given pars plana. 2 partial thickness scleral flaps were made and a triplanar sclerocorneal tunnel was made. Then using a NVR needle, 2 sclerotomies were made on both the sides. Then thorough vitrectomy was done to see if any residual matter was again left in the sclerotomy side or in the AC. Then we are entering the AC. Then a 3-piece foldable IOL was inserted. Then we can see using the handshake technique where we are using the end grasping forceps to externalize the leading and the trailing haptics respectively. And here using a 26 gauge needle, we are making a chariot's tunnel. Then the externalized haptics are getting tucked into the tunnel. Then we are closing the scleral flaps. Still the pupil remains to be peaked. So to remove any vitreous tag, if it was there, we are checking it doubly with a vitrectomy cutter and a dialer. Then the peritomy was closed along with the removal of the corneal sutures at the end, and the wound was closed along with placement of a BCL. Then after 1 month, we saw the patient in the day 1 post-op after SFIL, and after 1 month, the visual acuity was happily 6/24 parts. Then after correction, it improved to 6/9 and N6 after addition of plus 2.5. Then the IOP was completely normal and fundus was normal. And then we called him for a follow-up after 3 months. So in this slide, what are our key takeaway points? When it comes to a case of pediatric cataract, first, we should take a proper history and document the case. Ocular biometry and anatomy of the fellow eye should be taken into consideration. And pre of B scan and X-ray orbit is a must. First, to rule out any RD, choroidal detachment or retained foreign body, and also for documentation in case of MLC cases. In the intra, we need to take care that the corneal wood should be perfect and care should be given to the natural anatomy of the eye, and a thorough vitrectomy should be done. This trauma can induce angle changes, and hence we need to go for routine IOP and fundoscopy. Then adequate oral and topical medications should be taken care of, because in traumatic cases, they always predispose to infections, and the patient should be called for annual visit. Visual rehabilitation should be taken into consideration along with amblyopia therapy, especially in pediatric patients. So at the end of the presentation, I would be having 2 questions for our respected experts. Sir, what is your preferred management for aphakia in such children and why? And your choice of evisceration in children in severely traumatized eyes.
Thank you, Shraddha. That was a very confident presentation from a second-year PG resident. Sableen ma'am, would you like to take up the questions, and if you have any comments to share with us?
Thank you, Shweta. Thank you for having me here. And for, again, as Shweta said, for a second year, Shweta, congratulations to you for a very confident presentation. And thank you, Shweta, for sharing the case. I think there are lots of points that we can discuss. And general comment is the timing of, I think, cataract surgery in cases of pediatric trauma is in itself, a topic of debate. Because you want to do early traumatic repair for sure, but combining it with cataract surgery early to avoid amblyopia, and of course, if you have a lens rupture and raised IOP, and sometimes when you're repairing, the cortical matter just keeps coming and you anyways have to do it. And somehow I favor a little bit of delayed surgery, cataract surgery, if I can, if provided there is no rupture and then there is no glaucoma, because as you said, the first question, the aphakia, I feel that if we delay cataract surgery, if we can, if we do not have any complications, pediatric cataracts do not become Morganian, they become fibrous, and you have a nice scaffold over which you can actually place an IOL if you sort of do a delayed surgery. And you do a better IOL power calculation, you can implant an IOL in the primaries. Anyways, you're doing 2 surgeries. So you repair and you do a CSF 6 weeks. So if you can wait for some time, you get a little quiet eye. And early repairs, if the child is not showing, it's a small child, you can't monitor, especially the reaction after IOLs, to my mind, in the primary setting, is a big no. So then if you want to discuss this, or maybe we can have other comments. I think Dr. Vivek is an expert in trauma itself, so we can ask for their comments on what they say about the case.
I completely agree with Dr. Savlin. In acute stage, it's always better to delay the cataract surgery. Now here, we usually come across 2 dicey situation. So the most important is whether the anterior capsule is open during the primary injury, where the cornea surgeon usually plan for CTR. So if it is open, then I think it is ideal to, in the same setting, whatever the lens matter that comes in his way of, because that's a completely different way of dealing the lens material by the cornea surgeon versus the pediatric cataract surgeon. So I think if it is anterior capsule is open, then it's prudent to take away all the cortical matters, because it's a source of constant inflammation, and then you can leave it. As Shavlin said, over a period of time it becomes fibrous, and then the secondary surgery later on, not less than, in my practice, 6 weeks to 2 months, until the corneal tear heals properly, and the the shape of the eyeball is very much organized. So that makes a lot of other assessment before the the second step cataract surgery makes easy. That is one situation. Number two, if the anterior capsule is not opened, still I would prefer to complete the CTR and then wait it for the later surgery. Sometimes what happens, we do see a patients where and a later stage they have not have a corneal injury, but rather they have the anterior capsule tear. With those tear margins of the capsule, they are pretty much fibrous. So you can apply the different techniques if you plan these surgeries little later on after the acute phase get overcome. So I'll show you in my presentation, because the ultimate goal is the bag within the lens, and that's how what Shraddha has shown. Probably here also, while doing the lens aspiration, you can do a nice PPC with anterivitrectomy. And I think in this particular case, there was pretty much well organized corneal trauma, very well managed, and there was almost a normal anatomy of the iris and the even the sulcus or the peripheral capsular bag. So we can still revive the capsular bag, and later on can plan the sulcus IOL within the sulcus. However, there are n number of ways, like SF-IOL is also a good choice. There is not a kind of first or a second choice. However, in kids, in my practice, I usually don't prefer something in and around, the IOLs fixing onto the sclera, because as they grow, over a period of time, that becomes a constant source of inflammation throughout their life. That's all from my end. Thank you.
Sahitya ma'am, would you like to share your experience in such cases?
Thank you. And most of the points have been covered very well. So like both of Dr. Vivek and Dr. Savleen said, we also prefer a delayed cataract surgery, and we try to get either an in-the-bag lens or a sulcus lens. Initially, if at least the PC or the sulcus is still there, it's always a safer lens to stay inside. And a few points and the presentation was absolutely brilliant for a DNB postgraduate. So congrats to you. And the B scan pre-op in an open globe, when you have vitreous and everything, coming out, we slightly tend to follow not doing a B scan, or even for that matter, an IOP assessment when you have an open globe with everything jutting out. So maybe that could do more harm because it's in the technician's hand, the child goes back and forth. So we try to ideally do a gentle B scan, say on POD 2 or POD 3 and like that. And in our practice, especially from the place that I come from, Madurai, we have a lot of kind of vegetative injuries like the bird beak and these farm injuries and all that. So in such cases, we've seen when you have something like this, when there's a corneal tear and a lens has matter, vitreous and everything coming out with a PCR, sometimes on table, though we don't put an IOL, we see the intravitreals have helped. So we have the retina people come in, give intravitreals, or sometimes a pediatric ophthalmologist also does. So it has shown to reduce a few end-off cases for us, especially for injuries which are not that, metal or on all that. And farmland injuries have shown us these kind of things. But we also prefer to do a good suture removal, see a clean eye, and then do a good IOL power, correct it for the sulcus or in case of the SF-IOL, and then plan it accordingly, because putting an IOL may be your first step to a good eye. However, if there is a glass power which the child is not going to wear, amblyopia is going to come back and ruin everything that we've done. Six weeks post-op, everything looks nice, but then 2 to 3 years later, when you see the child not wearing a glass, coming back to you with amblyopia, then it really hurts. But it was a very well-managed case, and yeah, so.
Yeah, I
congrats.
think I just quickly wanted to add, Dr. Saitya has added a very important and crucial point, that whenever there is an open injury, that's how, the prognostication in terms of Bates classification. So it's always to do a gentle B scan. And whenever the injury is extending to the limbus, by convention, until proved otherwise, you need to suspect the traumatic endo, even if you have very subtle or minimal, opacities in the B scan. So once it crossed the limbus, then until proved otherwise, and it's, as she mentioned, it's good to inject in the same setting the intravitreal injection.
Thank you so much.
I
Just
think
one
in
last
this
question.
case, in this case, no intracameral antibiotics were given, if I'm right. Number two is that the corneal wound is pretty clear, but the anterior capsule definitely disrupted, and means on B scan it is not proven that posterior capsule is disrupted, but once they clear the lens matter, posterior capsule is also disrupted. So the very act of lens matter removal is been supported. Actually, that was done. But while giving, you need to observe for minimum 6 weeks. And here the suture removal was not done, and you gone for intraocular lens implantation, which is a little bit odd. First, you need to safely remove all the sutures and safety. In children, at least minimum of 2 months should be given. Otherwise, these sutures, there can be gap can happen in children. They are very notorious. Gaps can happen unless it is 2 months waiting period, and alternate suture need to be removed. Otherwise, wound healing will be difficult. And if you see the videos, again, there is no proper check was done for the vitreous in the anterior chamber, whether it is there or not. Means either you use steroid, the translone injection or not. And the air bubbles, if you see, there are multiple air bubbles were there in the antechamber, which is not a good indication. Though I know that you probably must have ruled out any vitreous in this thing, but when there are multiple air bubbles, it's not a good sign of no vitreous in the antechamber. That need to be ensured. Single bubble in the antechamber will at least rule out the vitreous in the antechamber.
So rightly pointed, I just said that at least 2 months time is needed. I had one case where there was a limbus to limbus tear, and he was early taken up for the SFIL, and on table the gap happened, and again resuturing was needed. In this case, the tear was actually not very large, and I was very much comfortable with the outcome. I knew that it is going to heal in 6 weeks, so patient was taken up at 6 weeks. And use of the tricot is definitely, you have rightly pointed out, it helps in checking whether there is vitreous in AC or not. So I was pretty comfortable. I knew that there is no vitreous in the AC after the first surgery also and the second surgery also. So I usually don't use tricot very frequently when I'm sure that there is no vitreous in the AC. So yes.
And moreover, whenever you have a score, like you had said, 7 score, nowadays there is different score system for ocular trauma and pediatric OTS. It's not OTS, it's now POTS, pediatric ocular trauma score. And now we have come up with toddler ocular trauma score also, because child cannot say you what's they can read or not. I agree with all the doctors, and mostly I agree with Dr. Ajit sir. We also wait for some time, and it was very nicely placed sutures, like placement of sutures, small sutures from center to periphery. She increased, and it was a wonderful case. Taking care of aphakia after 2 months, we usually use our own sclerotic IOL and our experience. Yeah, I agree with Dr. Vivek. Child is growing and fixation to sclera is little difficult, but in our study, we have seen that it works very well with traumatic, and we have a large series of pediatric traumatic cataract, and we have used this sclerotic IOL where you don't need any suture, no glue, nothing. I don't have any financial interest, but it is working well. Thank you so much.
No, but ma'am,
Wonderful case.
And it's a
do
nice
you implant the
presentation. We should
fixated?
compliment Shraddha for her presentation.
Absolutely.
Thank you, sir. Humbled, sir.
Yeah, Dr. Anurag, please go ahead.
Yeah, I was asking, does anybody implant still fixated?
Anurag, you are not audible clearly. You need to.
Okay, just give me a moment, sir. Okay, good.
Now, am I audible?
Yeah. Yes.
Okay, so my question was, My question was, since Dr. Shreya was discussing about the scleral fixated IOLs and she's got excellent responses with them, excellent clinical results, would you implant an IOL and tuck it in the sclera even with adequate capsular support as this particular patient had? The reason why I'm asking this is this patient already had a 1.5 diopters of cylinder in the corneal plane, as we saw in the biometry report. And mind you, the sutures are still not removed. After the suture gets removed, it goes bizarre. It goes very, very, out of scale. Scleral fixation of IOL in pediatric age group actually causes a lot of lens tilt in the future. We might be justified in doing it if we do not have a capsular support. That's point number one. The point number two is when we are hanging it from the sclera, we essentially leaving behind a gap between the IOL optic and the posterior capsule. So even in the presence of a primary posterior capsular excess and a good anterior vitrectomy to remove the scaffold, we have seen PCOs happening, and they're very bad PCOs, fibrous PCOs. So me being in this place, I would probably have not probably not, definitely not put in a scleral fixated IOL. I would have implanted a multi-piece IOL in the sulcus. And these are situations wherein I would think about doing a good PPC and in fact doing an optic capture, though that's not something I would do normally. But in these sort of cases, particularly when the child is very young, I would consider doing that because that at least gives the lens a stability in terms of a tilt. So whatever cylinder you're left with when you are carrying out the surgery is perhaps going to be the cylinder the patient has to manage even in the future. That's the only thing I would have done differently. Otherwise, very well managed case. I agree.
Sir, I have a question because we are operating these patients under GA. So one GA for traumatic cataract removal, one GA for suture removal, and another GA for the secondary IOL placement. So what I do is, whenever I think that the suture placement is causing a significant change in keratometry, then only plan for the suture removal first and then go ahead for the IOL. But in this case, the cylinder was 1.5 and my suturing technique, I'm sure that it's quite nice. So I was sure that after suture removal, I will not get a very significant change in the keratometry level. So keratometry value. So that is why I did not remove the sutures and then go ahead for the secondary IOL, but did the same in the same setting. So
Absolutely, I agree with you. Absolutely, Shweta. In this particular case, wherein you put in six, she said six, but I counted five. But if you are managing such small abaxial tears which are not covering the visual axis with 4 or 5 sutures, you can jolly well leave them because you're not doing anything. You're not implanting a toric, so you don't need to calculate the astigmatism that is left behind very meticulously. Aseptic inflammation happens, either epithelialization happens if you have buried the suture knots well, then they just fall off, getting loose over a period of time, and just you touch the bud under a slit lamp and they fall off. So you might be justified. What you're saying is right. Certain equations have to be weighed, in a balance. So what you're saying is absolutely right. 3 GAs vis-a-vis 2 GAs and managing the amblyopia with IOL placement and not removing the sutures. However, as Dr. Ajit was suggesting, out of those 5 sutures, since you were taking up the case after 1.5 months, you could have reduced the suture load by removing alternate ones. Maybe you could have removed 2 and left 3 behind, or removed 3 and left 2 behind. If the wound looks ragged in a particular area and you have put in a suture there, just to maintain the compression strength, you could leave that suture behind and remove the others. That was one possibility you could have adopted, one modality. Yeah.
very well said, sir. Point taken. So with that, I think we'll move on to our next presentation. It will be taken up by Dr. Vivek Vakar. Over to you, sir.
Yeah, can you hear me and can you see my slides?
Vivek, you need to be a little bit more loud so that.
Yeah, can you hear me and can you see the slides?
Yes, we
Yes,
can
we
hear you,
can.
Vivek. Please carry on. Yeah.
Yeah, so basically, the title of my talk today is Traumatic Pediatric Cataract, How to Manage by Using, the iris claw IOLs. And I'll share you my experience with this new technique that's called as a banded technique to deal with traumatic cataract. I do not have any financial disclosure. So why the traumatic pediatric cataract is important? I think almost 20 to 50% of all ocular injuries they occur in children's. In India, if you look at 7 to 15% of the childhood blindness is due to the cataract. So I think the incidence of traumatic cataract is reported to be, as high as you can appreciate here, 30% of all childhood cataract. So I think that's how the pediatric cataract is the most important, and for a pediatric ophthalmology, it is a big challenge to rehabilitate these children's. So I think visual prognosis in children with traumatic cataract is often poor for obvious reasons, because of increased inflammation, risk of amblyopia, and concomitant injury to other ocular structures. Again, the important consideration is because of its unilaterality, better chance of visual rehabilitation if we intervene at right time and treat it promptly, and being the atypical intra and post-operative course due to presence of intraocular inflammation, posterior synecdoche, and anterior or posterior capsular tear. So I think this I'll take you through an anecdotal case of 15-year-old female child who had a conspicuous history of the ocular trauma, and she presented with decreased vision in her left eye during the school screening program 3 months ago. So on anterior segment examination, you can see that she had a very gross loss of vision. However, the orthoptic evaluation was within normal limit. So she had iridodonesis, and there was a sluggish reacting pupils. If you look at that, there was a kind of subluxation of cataractous lens with zonular dialysis extending from 1 to 6 o'clock. So this particular child, I took it for lensectomy and then planned anterior vitrectomy along with implantation of, the iris claw IOL. So this is the simplest form I could record and present here, how to do the iris claw IOL. So I think you need to make a major corneal wound depending upon, what is the optic size of the optic of the iris claw which you are using. There are different types of iris claws that are available. So here, once you make the main wound, you can put the IOL onto the in the anterior chamber onto the surface of iris. So I think technically, if you see the video, it's pretty easy. So once you put the IOL in the bag in the anterior chamber, you can rotate it, and you can make the two side ports at 3 and the 9 o'clock. Depending upon, sometime you might have had different type of the iris damage in traumatic cataract or traumatic ocular injury, so you might need to do this procedure sitting at temporal side or the superior or sometime superotemporal. So here you can appreciate that I am holding the IOL with iris claw holding forceps. Then you need to take iris claw hook, and you need to press over the surface of the iris, and you will find that there is a click sound during the enclavation. You can feel that sensation in your hand. Once you do it for one side, then you can safely go to the another side, negotiating the overlying iris margin, and then again you can do a similar step, making sure that there is a click sound, and you can see that enclavation mark, that dimple onto the surface of the iris. So once you are pretty sure, you can safely leave the optic, and then you can see that the IOL is in place. So that's how this is being done. I think these two instrument, as you are saying, iris claw holding forceps and the hook is very, very important. So if you see the this particular patient, I had an intraoperative complication. When I completed this, I realized that the IOL is one of the the enclavation that has been released and de-enclaved, and the IOL was hanging into the anterior vitreous cavity. So again, it's a big challenge, to retrieve the another end. So it takes some time, but you need to keep patience and try to bring the optic into the anterior chamber over the surface of the iris, and again you can hold it and complete the procedure. So what I have learned from this first complication when I started doing long back iris claw IOLs is you have to make sure that you have opened that claws at the side haptics. Sometime by the company itself, sometimes they are not well opened. So you need to give a trial outside before you actually put the IOL into the anterior chamber, and then struggling with this one of the intraoperative complication. So this particular patient followed up over a period of 1 week, showing pretty much stable IOL in the place, and you can see that the vision had showed increasing improvement in the trend after putting copious topical steroids, antibiotics, and then started on the patching therapy. Then, as a part of routine check for usually the closed globe injuries, this patient was sent to the glaucoma clinic, where the gonio was done and the OCT was done to make sure that the IOL is in place. So the vision was remarkably improved, and IOP was within the normal range. So there was no other treatment for the glaucoma. However, these eyes always should be followed over a period of time for angle recession. So I'll just share a few post-operative complications I came across while doing these IOLs. So if you see the first image, day one pretty well. After 2 weeks, the patient came with, IOL came onto the surface of the iris. And then this particular patient, I had to take again back for, the re-enclavation and re-implantation with the iris claw. So I think what I have learned, I'll just run this video fast. First of all, I tried to find whether, I can reach the after dilatation, what happened? The IOL again hanged into the anterovitreous cavity. So I was just trying to release the suture and hold the hanging edge of the haptic. So it's I was trying almost 5 to 10 minutes to struggle to get. Every time I try to hold it with the dialer or hooks, it used to slip. So here I learned that you don't need to waste your time in trying to catch and bringing onto the surface of iris in the antechamber. Rather, you open the main wound and press the posterior lip, and the lens automatically the comes up, and you can very easily secure into the antechamber over the iris. So that's how this particular complication you need to manage, go back and the do the reimplant for these kind of complications. Can you hear me? I felt there is some disconnect.
So we can hear
No,
you. You're audible, sir.
it's audible, Vivek.
Yeah, because my video is not running. It's showing, it's stuck at.
Yeah, the slides are stuck, but we can hear you.
Yeah, I'm trying to move to the next slide, but it's not moving.
You can reopen. It will not work otherwise.
Yeah, I think it has jumped. So
Moving.
basically, you can see that this particular patient, after refixation of the iris claw at 2 weeks follow-up, the IL was in place. And usually these patients, the pupils, most of the time we feel, pupil get distorted. But believe me, if you do a proper technique, usually you will achieve a very good round circular pupil in post-operative period. So if you look at the literature, now the iris claw IOLs in a pediatric age group, it has been very much established that, they don't have a significant long-term complications. There are a number of papers which gives, quite good evidence that, the rate of complication is very much reasonable, and we can always consider this procedure as one of the choice in pediatric age group when there is no sulcus support. So with this, I would like to conclude that overall risk benefit ratio, I think these lenses are acceptable. Learning curve is shorter and operating time is lesser. However, longer follow-up is necessary to look at the long-term complications, particularly in this tender age group. I'll move on to the next case where I had this particular technique which I use where, there is the anterior capsule which is ruptured. And usually these are the patients who present, pretty late after the primary ocular injury. So as you can appreciate in this video, there were a lot of synecdoche in and around the fibrous margins, lower margin of the anterior capsule. So you need to be meticulous to, remove those synecdoches without much stretch onto the capsule, so that you can preserve the anatomy, because you need to do the rest of the surgery with the completely different intent of, letting the IOL in the bag implantation. So you can appreciate here how the lens aspiration is being done. So you can see that this is the, the tear which is in the center, the fibrous capsule, anterior capsule, and there is one more torn, another edge of the anterior capsule, which is along the margin of the pupil. So once you do the complete lens aspiration throughout the bag, then you can make the main incision, corneal incision, which is the routine. So now you can see that here you need to do a half rhexis in the part of the anterior capsule, which is the major part. Here you can see that on the right side in this video. So I have made the half rhexis. So the concept is, once you make the half rhexis, what happens, you can see that you can appreciate the pediatric rhexis forceps is being used to make the half rhexis. So this central fibrous anterior capsule moves towards the periphery, towards the, the margin of that half rhexis. That's the concept of this traumatic cataract banded technique, which is first brought into the literature by Dr. Kane Nischel. So once you do that, so there are two options depending upon how large the opening in the anterior capsule. So here you can put the IOL between the fibrous anterocapsular margin, or you can put the IOL if the half rhexis is larger enough. So I am just trying to implant through the fibrous anterocapsular margins. So once you do that, then you are pretty sure that, IOL is in the bag. So now the advantage of, doing the PPC and AV is the half rhexis opening. So you can always go through that half rhexis opening by negotiating the IOL behind, and then do the PPC AV. So that's how we are still able to put the IOL in the bag and do the anterior vitrectomy and PPC. So you can see, so I used to negotiate the IOL gone behind through that half rhexis opening, and now completed the anterior vitrectomy and PPC. So that's the advantage. So how does actually, what happens in this particular technique? If you see, Dr. Nichel has published 5 cases in a series, where he has shown how the fibrous anterior capsule that retracts towards the periphery, clearing the central visual axis to have, the better rehabilitation and IOL in the bag implant. So these are 2 cases which I would like to highlight here. You can appreciate here. These are recently I submitted in the journal, where you can appreciate that, the center, the band, the fibrous intercapsular band that starts retracting towards periphery, clearing the visual axis. So that's how it's a double-edged advantage of letting us IOL in the bag, and you can do very safely PPC and AV without any complication. Thank you very much.
So that was a very, very nice presentation. Any comments from the expert panelist?
Can I make a
Shreya ma'am,
comment?
Sablin ma'am, yes,
Yeah.
please.
So wonderful cases, Vivek, that you showed. I just have a few comments for the iris claw because I mean I totally appreciate what you've shown, and I totally believe in the iris claw technique in children because nowadays I've started doing it for more and more for ectopia. But because we have a young audience also watching, I would like to put few disclaimers for the iris claw that you have to have a very healthy iris for an iris claw in a pediatric trauma case. And it's only a blunt trauma because you will not get this kind of a nice iris for a claw lens in a, in an injury that the previous case was showing. So, biggest disclaimer, you have to have a healthy iris. And I support iris claw lenses, but I prefer doing the scleral pocket with the limbal incisions for easier manipulation. And for beginners, I always tell them to put a 10-0 nylon on maybe one of the haptics so that it often gets disengaged, so it's easier to retrieve it. At the end of the surgery, you can just remove the suture that you have passed. But yes, getting these clean, blunt trauma cases with a very healthy iris for an iris claw is you have to be really selective. And secondly, for the bandit technique also, somehow I feel without even doing that small, opening that you made, the band still retracts. So I wanted to try, but I just like to put the IOL and then maybe, with a vitrector, take care of the extra fibrosis. I do not go into that extra effort of making the small opening because I somehow feel that even if I don't do it, that's how I have experienced that it still retracts and it gives me the advantage of in the bag. But I'm open to comments from other panelists. Thank you.
Yeah, I think we had this discussion during one of our POSN session with Dr. Nishal. So what happens? It is always because it's take extra half second or probably the 1 second, and if those bands, particularly the one which is in the center, if it is pretty much extended to the periphery, then the retraction towards periphery is a little difficult. I had one patient, these are all old cases, but after that I have done almost 5 to 6 cases where actually it didn't move. I tried this, it didn't move, and then it was like almost 3 months, 6 months it is in the center. Then it was again the problem whether go back and the once you cut this, then the entire the entire capsule is pretty large and then very high risk of IOL coming out. So that I had, so I always do this extra step and get away with pretty confidently.
Very nice cases, Dr. Vivek. One thing I would like to ask is, do you routinely do a PI in the cases where where you use iris claw lens, or?
Yeah, I think this is very nice question, Ruby. Initially, 5 to 6 cases, I had seen very high risk of pupillary block glaucoma. When you try to remove the suture, sudden opening of the suture that happens, and then I'll completely change my practice. So every patient I do a safe PI, small size PI at superior quadrant anywhere where it will be hidden under the lid.
Just one comment. It was a very good presentation. Can you hear me, Vivek?
Yes, please. Yeah.
So that band technique which you have taught, we have also done it, and that gives a good result. But one thing I wanted to ask you about the iris claw. So it's basically, if you have a very clean, as Evelyn was telling, a very clean cornea, iris is good. There is no pupillary margins. You don't have any corneal marks in the pupillary region. Then we can go ahead with this type of iris claw because that gives us a good results. But usually we do it for ectopia lentis cases, most of the cases. So in these cases, the most important thing what we have seen is how many cases do you have any endothelial loss in these cases, and did you find any IOL tilt in your case? Because this long-term what you are taking care in the long-term process? How long have you followed your case?
Yeah, so I think I have now a couple of follow-ups up to 3 to 4 years. Number one, number two, we have not looked for endothelial loss, but definitely the iris posterior fixating IOL being very unlikely that they would cause endothelial cell loss. And the most important thing is with the last question, what you asked.
IUL tilt, how many IUL?
Yeah, tilt is that is the biggest advantage over the this scleral fixating IOL. So in initial few cases, I always used to do inter-segment OCT and see how's the IOL. Over a period of time, they are like pretty flat along the iris. So I have never seen the tilt. Rather, sometime distortion depending upon how primary surgery you have done, less traumatic to the iris. You will have kind of slit-like pupil or little irregular pupil, but I've never seen tilt in this group of patients.
No, the endothelial cell loss happens, Vivek. It does
Yeah,
happen
I
within
mean, we have
iris
not
claw.
looked. There might be ongoing
No,
endothelial.
what is interesting is what I'm bringing to your notice now. If you do a sectoral specular microscopic study, you will find that the central corneal endothelium actually does very well with the iris claw posterior fixated. But if you go to the periphery where you have enclaved them, the tremulousness of the iris actually causes a lot of endothelial cell loss. This was brought to my notice by Professor Chi Soon Fek, and she said, I have completely abandoned iris claw IOLs just because of this. Interestingly, when I heard it from her and I went back and I studied all my patients who were coming for follow up, what I saw was I don't actually normally do it in pediatric patients, even if it's an ectopia. I would always prefer to fixate the bag externally and still go ahead with the in the bag implantation or in the sulcus implantation, keeping the bag as a support. Because by the time the suture degrades, the capsule actually is enough fibrous so that it helps the IOL being placed in, held in place. It's not a ectopia lentis is apart from very few specific situations like the one you showed is traumatic, so it's not a progressive zonulopathy. You just have to manage the zonular loss that has happened before the surgery. Children, when there is a sectoral endothelial cell loss in those two sectors in the periphery of the cornea, children have somehow been shown to resist those endothelial cell losses much better than adults. So even if the cell count or even the hexagonal cell percentage is low in those sectors, there's nothing that manifests on the cornea. So that's one thing that is a blessing for us.
Yeah.
Talking about your second technique, Dr. Asim Sil actually was talking about this technique some years back. I don't think he's published it though. He used to call it the seat belt technique. He used to call it the seat belt technique, and his idea was very right. He was saying that if you have a badly traumatized lens, the seat belt that you leave behind, the band that you leave behind, actually supports the aisle in the initial part very well. And as you rightly pointed out, it retracts to the periphery. Now, when a 1 in a million situation wherein you said that one of the cases it did not retract, then it occupies the visual axis.
Yes.
So, forgive me for saying this, but honestly, I actually fail to understand the rationale of this, to be perfectly honest with you. Because after you put in the IOL, what's the harm in giving a small nick at the center, central to one central half and peripheral half, and just encircling it in the form of a rexus? That actually causes 100% retraction in all the cases. So you don't have to worry about the band coming in the visual axis, but different takes to the same thing. But it was very, I just wanted to tell you that though he had not published it, but Dr. Asim Sil from India was actually I heard it from him for the first time, and that was good 5 years back.
Yeah, I think usually what happens now, my only worry is, the angle recession glaucomas. So if they are there, then, putting, otherwise it's like you cut everything, do a nice PPC AV and put the sulcus 3-piece IOL. That's the best rehabilitation one would do. But especially I choose this deliberately when there is an angle recession and I'm really, want to put the IOL in the back where I don't want these complications later in the life.
No, even with a single piece IOL, after you put it, you just have to. The case that you showed, it had an open mouth in one of the sectors that was peripheral. So give a small nick at the fibrous band and then rotate it round to complete the rexis. So it will be 2/3 rexis open on one side and the capsule open on the other, you can still go ahead and put in a single piece IOL with the haptics in the maximal capsular support zone. It works very well. Yeah, I mean,
Actually, it is not always that way. What he was trying to say, if you have a band, so he was trying to tell you how much rexes you can make, you make it so that it goes back. What exactly you are saying, if you are giving a nick, you don't know how the band is. Sometimes the band may not be actually, you will be seeing it, but actually it may retract back. So you may be losing the entire bag itself. So that is what he was trying to make, that a smaller rexes and you put in your IOL, then you are safe, it is in the bag, and then you extend it further. That is the rationale behind this type of a technique, or you can actually modify your technique accordingly.
yeah, right.
Sir, a very nice presentation. I'd like to add on to Dr. Anurag's point. I also heard it from Dr. Asim Sil, and I've seen his presentation on the seatbelt technique. That was around 2020 or so, 2019 to 2020. Yes, and he had about 20 to 22 cases which he showed me with pre-ops and post-ops.
Right. But I don't think he published it. That's why it goes to Dr. Nishal. The credit has to go to him for describing it on literature first. Yeah.
He had a good presentation with 22 cases and all great outcomes.
Yes, absolutely. True.
So that was a very nice discussion. Thank you so much, the experts. I'm getting so much of knowledge here. Very nice. So with that, we move to the next presenter, Dr. Shanmuga Sundaram. He is a senior resident at AIIMS Bhubaneswar.
Yes, ma'am. I'm sharing my screen.
Please share, please share your slides.
Is my screen visible, ma'am?
Yes, please go ahead.
Yes, ma'am. Good evening, all. I'm talking about the pediatric trauma. Globally, the annual incidence of pediatric ocular trauma is nearly 9 to 15 cases per 100,000 population. Especially in India, a study by Hassemi et al. By the year of 2022 reported that there is 5.2% of prevalence of ocular trauma in a population of 6 to 12 years of age group. But among the childhood blindness, the ocular trauma itself is accounts for 4.2 to 7% percentage of blindness. So knowing this, we are going to our first case. My first case is a 6-year-old male child presenting with complaints of right eye pain and loss of vision and watering and discharge for past 6 days with an alleged history of injury to the right eye with a stone which happened 6 days ago. So on first day of injury, patient went to the nearby hospital. They advised for the primary repair, but patient didn't go for the surgery. There are no other injuries or no other systemic illness for the patient. And examining the patient, right eye showed the vision of the patient is only perception of light with the PR was inaccurate and left eye was fine. Then extraocular movements are full and free and mildly edematous and sticky lasers here in the secretions we can see here. Then conjunctiva was congested. In the cornea, we can see there are edematous portions surrounding the laceration. There is a full thickness laceration extending from here 11 o'clock to 4 o'clock area through limbus to limbus. Then we can see the iris tissue prolapse coming out through the injury. Then the anterior chamber was irregular in depth, which shows fibrinous exudates in the inferior portion, but the superior portion showed clear iris. But pupil and the lens status are not clearly visible, and the other eye was fine. And then the fundoscopy of the other eye also was fine. Then we did an imaging. Then imaging showed there is some hemorrhage in the right eye, and the left eye was fine. There are no retrobulbar or intracranial bleedings. So we came to a diagnosis that it is a right eye type A zone 1 and 2 and grade 4 open globe injury with raw points of 30 and the ocular trauma score calculated as 1. So in this, the estimated vision of follow after 6 months, it will be 73% of chances of no PL and 17% of chances to stay in PL positive state. So we have counseled the parents and we have admitted the child and planned for an primary repair with intravitreal antibiotics and started on topical antibiotics and injectable antibiotics, and eye shield application has been given in the preoperatively. Then intraoperatively, the extra debris are all cleaned, and then side port is made. Then anterior chamber has been filled with the visco. Then peritomy is done to look for any extensions, scleral extension in the 4 o'clock side. There are no extensions, and same we did in the 11 o'clock side also. We have seen 3 millimeter of extensions here. Then the prolapsed tibial thesis are cut. Then the scleral injury has been sutured with 80 vehicle. Then both the ends at 11 o'clock and in the 4 o'clock, two stay sutures, two limbal sutures are given to maintain the corneal integrity initially. And then we started with the periphery. In the periphery, we have given little bit lengthier sutures. Then we moved on to the center. As it goes in the center, the suture size reduced, but as because of corneal edema, we are unable to give very small sutures. So we still given little bit bigger sutures only to hold the corneal tissue to oppose. Then by end of the procedure, we have given intravitreal antibiotics, ceftazidime and vancomycin. And then excuse me. Then post-operatively, we have started with some medications as intravitreal, injectable ceftriaxone and topically moxifloxacin, prednisolone, and homometropine. Then dexamethasone has been initially given for 3 days. Then later started with oral antibiotics, which is 30 milligram as per the body weight. Then on day of first post-operative day, the vision was only perception of light, and PR was inaccurate. Shallow anterior chamber with the intact sutures we can able to see, and there is one suture we have given in the side port also. Then post-operatively B scan also done. B scan showed that PC status was not clear, and in the mid vitreous we can see some mild echoes. It may be either vitreous hemorrhage or the exudates, and there is some thickened retinochoroidal complex and some fluid accumulation in the subretinal spaces. Then follow up on post-operative day 2, we can see there are more exudates in the anterior chamber, and as it goes on post-operative 5, the exudates are reduced, and the axial length of the eyeball also eyeball looks enophthalmic. Then coming to our second case, it is a 14-year-old male child with complaints of left eye pain and diminution of vision and watering for 2 days. Alleged history of injury to left eye with the soft tennis ball while playing. Then there are no other injuries and not a known case of any other systemic illness. On examination, the patient had vision of 624 with pinhole improving to 612 in his left eye with an intraocular pressure of 36 millimeter of mercury, and the extraocular movements are full and free, and the orbital margins are regular with a mild tenderness. Then lids are mildly edematous and the conjunctiva is congested. Corneal surface was clear and smooth, and the anterior chamber was irregular, and the cells there are 2+. Here we can able to see the image. The conjunctival is congested with midriatic pupil showed some irregular edges here. I mean, because of sphincter tear, and there is a shallow anterior chamber noticed on this place. Then after dilatation, we have noticed an lens subluxation of from 12 o'clock to around 2 o'clock area. Then and performing gonioscopy, before dilating, we have done the gonioscopy. We have noticed there is an angle recession in the 10 o'clock to 1 o'clock side in the left eye, and right eye angles are normal. Fundoscopy was normal in both eyes. Then and perform the imaging, there are no retrobulbar or intracranial bleeds, and B scan also showed there are no bleeding in the vitreous. Then we made a diagnosis. It is a left eye traumatic lens subluxation with secondary glaucoma, and the calculated raw points was 90, and then ocular trauma score was 4. So with this score, we are expecting that after 6 months of follow-up, there are more chance, 74% of chances of the child to have vision of more than or equal to 20/40. Then initially we planned started on topical medication to reduce the ocular pressure. Started with two topical and one oral anti-glaucoma medication, and to relieve the ciliary spasm, eye drop cycloplegic also started. Then after 2 weeks, once the IOP is controlled, the patient has been extraction. Initially, the insulin has been given to stay in the Vidya. So after which we can see the vision. Sorry.
Yes.
I think it's done.
Ma'am, sorry.
Are you facing some issue?
Yes, ma'am. Facing some issues with playing the video. I'm able to hear me?
Yeah,
Yeah,
yeah.
you're audible.
Yes.
Yes, ma'am. I'm set once again.
Yeah.
Can now directly go and click the slide next to that video rather than the same video slide.
So post-operative, the vision was 6/9, and by end of the with the two glaucoma anti-glaucoma medications, the patient IOP is controlled. Then patient is on follow-up now. My take-home message is that early intervention and yearly presentation of any trauma will save the vision. If it is a closed globe injury, if it is an open globe injury, as like our first case, it is the best thing to do primary repair is only to prevent the sympathetic ophthalmia of the other eye. Then later on, we have to follow up the child to look for whether the eye is going for any thysis bulbi, or we can plan for evisceration also. Thank you, ma'am.
And that was a very nice presentation, Dr. Sundar. Dr. Ajit, sir, you wanted to say something?
The first case?
Yes, sir.
First case, at least it should have been managed a little bit better, because if you see, it is a limbus to limbus injury. The corneal tear repair was done, but they should have done the lensectomy part and antervitrectomy part, so that the end off would have been prevented. Though they have given antibiotics in the early phase, a little bit you need to be more aggressive in the first phase rather than only stopping at limbus to limbus repair. And they have given nicely the antibiotics, that I agree, but little bit more intervention should have been done.
Yeah,
I would also say that even in first case, if you could have used the AC maintainer while doing surgery, and at the same time you just very nicely clean the wound of cornea with anterior vitrectomy. It's very small vitrectomy, and you can make very clean wound. That definitely plays a role.
No, the use of
It's
visco can
already
be.
published in IGO. This video is published in IGO. So using, yes, sir.
The visco uses.
Yes.
From the other part, they have made the other part nicely. But
Yes,
they should
yes,
have used
absolutely right.
copious viscoelastic so that the dissection and the tissue clarity, everything will be much
Yeah.
better.
So using AC maintainer and vitrectomy cutter will
Yes.
be very
Yeah,
good.
Doctor.
Thank you.
Sir, just to comment, this was the case which came in the emergency, and has been done by the senior residents. So just basically
Yeah,
showing
I understand,
how
but
good they can. Yeah, but we
absolutely.
are
Yeah.
planning to pick it up as you are saying.
Yes,
So
yes.
he is just showing it, so it's being taken out now.
they must
But
be
the
listening. No,
thing
that's
is,
why I'm commenting.
Yeah. Thank
Yeah,
you.
Dr. Ajit, I just wanted to add, usually what happens, as you said, we have to be extremely aggressive, especially when, it is touching the limbus to limbus. So usually what happens nowadays in LBP, these patients, we do go by, the endoscopic approach to see what's happening in the posterior segment. And then we do a thorough treatment of the posterior segment through an endoscopic vitrectomy.
Yeah, that means whenever the dissection you do at the earliest stage, it becomes more easy.
Yeah.
Rather than if you see the post-operative, even at 1 week and second week itself, a lot of choroidal thickening that is happening, which will complicate the matters when you intervene. In the first case, the second case is totally different. That is like angle restriction of for 2-3 clock hours really do not cause secondary glaucoma for me. It should be 180 degrees. So you need to observe for the development of the glaucoma. That is number one thing. Number two, how much is the vitreous prolapse into the antechamber? Again, you need to see, because not all vitreous prolapse into the antechamber do cause any secondary glaucomas or any, even if it is a corneal touch, how much dense it is. The corneal adhesion, vitreocorneal adhesion, or even contact itself can cause decompensation of the corneal endothelium that need to be observed.
Yes, sir.
Ajit sir, I have one personal question to you. Sir, what do you think as a retina person, which IOL is the best for the pediatric eye? Because as a pediatric ophthalmologist, we prefer putting IOL in the bag, if not bag in the sulcus. Suppose we don't have the sulcus, we don't have the bag. We have two
Yeah,
options left, iris
last
flow and
discussion, you should have asked this question to all of them, actually.
Sir, now this is the end. This is our last
See,
presentation.
definitely, I
So
do not go with Vivek. Iris claw lens. But yeah, probably the scleral fixated with the Amanas technique, I do prefer, because see, there is no other IOL is suitable. And this child are individual, I would say individual, because child today, but after 10 years, he will become an adolescent and then adult and elderly. So very, very long course. So this endothelium is going to give away. That's why I'm a little bit skeptical about the iris claw lenses. But in adults, yes, Vivek shown beautiful videos actually. In adults, it's definitely worth trying them. But scleral fixated IOLs, if you are doing for, but in that case, which was shown in that, I would have kept enough capsular support while doing the thing, so that what happens is post-operatively this capsular rim becomes thick, and it will give enough support for the sulcus implantation of the PCI well, which will not cause any secondary complications or anything. That would have been more preferred technique rather than
Yeah,
even
I have.
scleral fixation.
Yeah, I have done couple of patients where they are like there is no support for a small clock hours, and they are not on the dependent part. They are on superior aspect. So still you can have, the good support and you can get away with doing sulcus
Yes, yes.
PCIOs.
Even the peripheral rim of capsule, that becomes all traumatic cataracts with these capsules. No, if you leave them, it becomes a thick
Fibros.
capsular rim. The fibrosis happens, and it gives very good support. So you give some time for it to get fibrous, then take it up for a secondary IOL rather than primary IOL implantation.
And so last question to all of you. Evisceration in badly traumatized eyes. How frequently we have done it? How we counsel the patient? Are we still doing it? There are some indications or not?
I think Dr. Shreya can take that.
Shreya ma'am?
You are muted.
Actually, yeah, sir. Sir, please. So you were saying something.
You
Yeah.
should.
Yeah, what the question rightly she asked, actually, we have published a series of 429 cases in Retina Vitreous Journal that says no PLI doesn't need to remove all the time. You have to have trial, even there is no PLI. In the modern traumatology, it is said that no PLI doesn't have to remove all the time. Until and unless, and so no destructive procedure unnecessary should not be done. You have to try.
At the first go, you should also qualify that at the first go. Second is no PL do not mean it is no PL. Okay. No PL with what you are testing and declaring that it is no PL. So
And even in our series 20.
VEP is the correct modality to say that it is no PL or not. Before that, you cannot declare any eye as no PL. And at first go, you should not go for either evisceration or enucleation. Give it the best try to recover, because we have seen eyes, because number of eyes we intervened and we have seen them recovering surprisingly well and giving useful vision actually. So
in our series also we regain vision in 29% of our.
Yeah.
So
good
should.
vision.
Yeah.
Surprisingly good vision.
Absolutely, sir.
Ma'am, any considerations for sympathetic ophthalmia?
Sympathetic ophthalmia, very few cases actually. I have seen one case in my all this thing. That patient went for court also. But we repaired this, the eye which got some useful vision. After that, he developed sympathetic ophthalmia. Then we had given IV methylprednisolone and stabilized. Problem what has happened is he lost to follow up and then came with very severe form. Even then we given, but again he was not having a proper confidence in us and then keep losing for follow-ups. That's where we lost his. Actually, the worst I got 2200 vision, and the better I lost to sympathetic ophthalmia.
So, do we give oral steroids routinely after bad injuries, or it is not needed? Even if we give the oral steroids, it is like a sympathetic ophthalmia will not develop. Is it like
Yeah,
that?
you should give. You should give. And if endophthalmitis happens, that is a protection for sympathetic ophthalmia. Somehow, many of you may not be knowing this. That's why I'm spelling it out. Steroid cover also we give post-trauma.
So, any comments from anybody, experts? That was a very, very great webinar. Thank you all of you for joining with us. Great information, great knowledge, and so many points I have learned from all the experts here. Thank you so much.
No, you have done very well, Shweta. Sachi.
Yes.
Wonderful, informative session for all.
Yes.
Excellent.
It's good.
Excellent.
Good, and we need to thank Sharmishta for giving all of us a chance.
Yeah.
I should thank you, sir. Can I go forth with the vote of thanks, sir?
Vote of thanks, sir. Yeah.
You don't need, actually, we should thank you, Dr. Sarmista.
Anybody wants to discuss anything more, please?
Ma'am, I
तो
want
आ
to
गया
add.
अभी
Sir,
Chittor,
I was
Professor
there
wants
only,
to say
sir.
something.
I was there only.
Okay.
Would you like to say some few words about SFIL, the
No, ma'am. Actually, I think being a B2 retina surgeon, my preference, of course, when there is no capsular support, we had great anti-segment pediatric surgeons, anti-segment surgeons. But if the age of the child is more than 7 years and there is bad iris or iris tissue loss and there is not adequate capsular support, I prefer for scleral fixated IOL. But I did not tell much because very interesting discussion, surgeries, nice surgeries by Dr. Vivek and all the panel they were discussing. But my preference will be SFL after because by 7 years the scleral rigidity comes. It is very adequate to put a scleral fixated IOL, and I do it in no glue, no suture, that modified Gabber's technique.
nice?
Yeah, you
sir,
won't believe,
Can we see you?
I'm amazing.
Can
Yeah,
we
I
Sir,
was
just
just saying
can we
a
see you?
lot
Yeah.
of because we do have 8 retina surgeons. All of them they do SFIOLs, but nowadays looking at long term, the flow of the patient, and we are seeing these childrens. I am the person where they usually prefer to refer whenever they can't, or from their angle or point of view, it is a contraindication. They send to me for iris trials. So that's how
Probably we need to wait for
my
1 or 2
greatness in
decades.
the institute where
No,
they are
Vivek,
referring those
1 2
patients
decades
to
and
me.
then we will come.
Okay, sir, I also feel that I've now seen a 15-year, 16-year follow-up of patients with scleral
That's what
fixated
I'm
IOLs.
saying.
Yeah, so
Absolutely.
even
It's very
I mean,
tough.
I totally believe in the technique, but for sometimes for kids, I think aphakia is also not a bad option.
Yeah,
Having said
FAK is
everything
not a
about
bad
IOLs,
option at all.
I think as
And
pediatric
I have seen
ophthalmologists,
scleral fixated IOLs falling, one of the haptics
yes,
falling after
we
7
have
8
seen
years.
suture extrusions,
Everything
breakage,
can happen.
yes,
In
with the
long-term follow-up, everything can
That is,
happen.
yeah. And that is the reason it is said that trauma is a teamwork. So what one person can do, one person can do, other person can do other things.
and I think we should not be scared of telling the parents
Absolutely.
that
True.
it's
Absolutely
we are
right.
leaving the child
We come.
aphakic
Absolutely.
and we
True.
give a good contact lens, and sometimes unilateral cases also do much more better than any IOL. I mean, we should have
Yes,
aphakia
contact lens
also
is
as
also
one of
better.
the
This
options.
this AIOS conference I learned in one of the session from Punjab. They have showed the 4 point iris claw fixation. So I was just searching, where does that lens is there available. Some ophthalmologist from Amritsar, he has presented. He gave the talk on that 4 point fixation. So don't know. I mean, we need to explore.
If you still see patients having stainless steel sutures, that's Dr. Daljit Singh from Amritsar. I think he has a hierarchy of iris claw lens supporters.
sir, I have one
So a
doubt.
very small point that I would like to add is when these parents and children come to us like with these type of injuries, it is also important to counsel them properly. Tell the parents that the children should be kept nil for oral so that the surgery can be done in early time. Also to give tetanus toxoid to these kids, and then with a proper covering of the eye, we have to let them stay for maybe 4 hours or 6 hours, depending on the child's age, and then take them up for surgery. So, proper counseling and explaining everything to the parents also becomes very important.
And one thing to add, Ruby, is the evisceration thing. I think maybe seniors are there, they can
Consent
opine.
and everything, yes.
Evisceration should be the last resort. Like even if no PLI is bad,
Already covered here.
Yeah, that's what I'm
Yeah,
saying.
that's what Dr. Shreya said.
And
Sir,
even if we're doing evisceration, you should not, even if we are not doing routinely, but even if you're doing, if you're leaving a bit of uveal tissue incarcerated in the wound, that is responsible for the sympathetic ophthalmia rather than not doing. So,
No, even vitrectomy port can cause sympathetic
absolutely.
ophthalmia. Please. So let us not say that whole evisceration, small tissue.
So one more thing
Okay,
to add,
madam,
sir.
Dharmishta.
So, sir, one more thing to add. Having said all these things and doing a very good, sir, can you hear me?
Yeah, please,
We
little
can.
bit more.
Loud. Sir,
Loud.
having said all these things and all the IULs which we have done, we have to counsel the patient that they have to regularly come back and do the
That's
ambulatory
what
therapy.
Ruby was
Because
telling.
without that, all the effort also goes waste. So these all
100%.
things are very important also.
And more important is, even if trauma is innocent, I tell the parents that I need to observe for at least 3 months before declaring that it has caused nothing. Anything can happen.
Sir,
Thank you, sir.
I want to ask one thing.
Okay.
Sir, first case, sir, in my first case, the vitrectomy is required in the same sitting or in the separate sitting? I want to know, sir. Because I have superior iris tissues I can see. The whatever the uveal tissue prolapsed is supposed to be the inferior iris tissue. So if we do vitrectomy in the same sitting, there are more chances of those iris tissue also get damaged, and my AC is also not forming properly. So first thing I have to do is to close the corneal wound. So close the corneal wound. After that, sir, I have to give an.
Yeah, corneal wound nicely closed, but you need to repeatedly form the AC and little bit more tissue clearance need to be done.
Yeah, that's what I said, that you should use vitrectomy cutter just to clean the corneal wound and put the AC maintainer so nothing comes in your way, and your closure will be wonderful.
Okay. So,
and the overall the areas should have been more clear so that end off should not have happened. That is the thing.
Okay, sir. Thank you.
Thank you. That was a profound learning today. Bit by bit learning. Special thanks to our esteemed expert panel, Dr. Ajit Babu sir, Dr. Sahitya, Dr. Sablin, Dr. Shreya, and Dr. Anurag, Dr. Sucheta, Dr. Ruby, Dr. Vivek, and both the speakers, Dr. Shraddha and Dr. Sanmuga Sundaram, for sharing insights and enriching all of us. A big shout to our wonderful moderator, Dr. Shweta Dhiman. Applauds. Great job.
Yes, my vote for her.
Yes.
Thank you so much.
And we are grateful to all the participants for their active involvement, and all the executive members and scientific committee for behind the scene work, and to Entod for providing us with a seamless platform. Thank you for the great support. Thank you for being part of this academic journey. Let us continue to learn, share, and grow together. Thank you so much.
Thank you. Good night.
Thank you, ma'am. Thank you all.